Um, Hello, good morning. A very warm welcome to this session hosted by CARE, in which we will highlight innovative and equitable solutions to empower and strengthen community health workers. Community health workers play a critical role in reaching vulnerable communities across the world, often working in very challenging contexts with no or limited pay, inadequate training, lack of career or leadership opportunities. And they're also facing significant gender-related challenges and inequities, as the majority of them are women. Last May, CARE launched an exciting new initiative called She Heals the World, in which we integrate programming, advocacy, fundraising, partnerships, and research to support community health workers, significantly improve their working conditions and quality of their service delivery, and really ensuring an enabling environment in which they can thrive. And we see a focus on community health workers as critical, considering that they provide care to around 5 billion people around the world. Investing in community health workers can prevent up to 7.4 million deaths by 2035. They contribute to the reduction of about $6 trillion economic loss annually due to poor quality healthcare. And for every dollar invested in community health workers, a country can see up to a $10 in return on investment from reduced costs of poor health and increased employment and productivity. So today we're very excited to share with you some local solutions for community health workers that are harmonized and coordinated with local partners, private sector and government to ensure their sustainability and reach. We will start with a video that shows a community health worker in action. And then we have a great panel of 3 panelists that will share with you their experiences and the solutions that they work with to support the community health worker workforce. So after that, we have another great video from the Philippines. And afterwards, we have time for a short Q&A session. Please feel welcome to put your questions in the chat or in the Q&A function at any time when the speakers are speaking. And yeah, we will try to answer your questions, as many of your questions as possible. So before I will introduce the first panelists, we would love to show you a video from Kenya.
Kwa majina ni Susan Sitonik. Nafanya kwa hii health center as a CHP. Na tunafanya sisi ndio tuseme madaktari wa huku ndani mashinani. In case kama kuna mgonjwa hajiezi, sisi ndio tunahakikisha tumeenda tuhakikishe kila mtu ako sawa kiafya. In case kama kuna mwenye ako na mimba hajaenda clinic, hiyo ndio kazi yetu. Nafaa kuchukua hatua. Tumefanya kwa muda trainings, tumeenda ya TB, tukaenda ya trachoma, tukaenda ya ora wena kata lameyu geti nto mono na to ishote nige ne bwa jore ngara na geti underweight, tukawashughulikia nige hospitali tene ndio ni hudumia ndio nisho ngurumolo shoro na nerum change ebani oninga jo meningire sidai ne hospitali ime nela kwa hospitali nemera means ya transport neeku kibidi na bege nyamale kitongoito ipokin pekedol ajo erabaua hospitali. Ndim sinine wenda sana ara ngera kumok tiaru aji pake nera ngera imiet na anda 5 eti pokira imiet asho neyu nelo nemera ndonga longo ikina duo kene nyana ndola ajo na challenges na ngera amitiki. Yani yekinteru duo ayudumia ndongana kitonga nti ndol ngera ini ndol ajo meningite sidai nihakikisha ajo ifuatilia wa hospitali nifuatilia ajo irogor kekene naishakino mpaka ndola ajo ishiu hata ngera imiet ngira bashi kundelea mama ore sininche openy na ore venye na yole ndogi naisha matonyora na sia kekidolta irmaasai lang egira apa aiumia.
I also just realized I forgot to introduce myself. My name is Marielle Hart, Global Policy Director for Health Equity and Rights at CARE USA, and I'm based in Washington, D.C. Very excited to moderate today's panel. So I'm very excited also to introduce to you Nadira Kanam. She is working as inclusive development advisor for the organization CNHA in Bangladesh, and she will speak about the Bangladesh Community Nutrition and Health activity funded by USAID that is addressing equity gaps in health. And CARE has led health partners in Bangladesh in being the first to conduct an equity gap analysis, which has provided essential insights into the health disparities among vulnerable populations in Bangladesh, and also particularly the role of community health workers. Nadira, so happy to have you with us. Over to you.
Thank you very much for giving me the floor. Yes, you already introduced me, introduced about me, why I am working with CARE and what I'm doing currently. So that is, we can go directly to we are working with the community health worker that already knows, and working with a USAID project we call CNHA, Community Health and Nutrition Activities, and it is a USAID project, and we are mainly focused on community health worker. We are trying to bridge community people to community health worker using the community groups. And the target group. This is before starting this initiative intervention, we conducted a equity gap analysis and try to find out the major challenges in health equity. So that is our major target group for this study was to women and married adolescent in under reproductive age group in ultra poor communities and hard to reach areas, and women and married girls from ethnic religious minority and excluded caste among Hindu and Muslim community, and women and married adolescent girls with disability and third gender population that we also try to cover under this study. The major findings to getting access to the health disparity for the vulnerable people. This is a major findings that I'm trying to share quickly. And the women and men from the minority groups are very much less aware about community clinic, what kind of service they are providing. And men knew very less about community clinic services. And they're not interested to go use any contraceptive to take support from them. Because they thought this is a woman's responsibility, not man. And men always prefer receiving healthcare from village doctors, homeopath, and quack. And women all the time, these vulnerable women from the community, they received healthcare service. They are not interested to take healthcare service from community clinic due to lack of availability of medicine, because there is a huge disruption, poor treatment or behavior of community health worker, and they're not satisfied. And the service hour, when open, when closed, they have no idea about community women. They have no idea, especially the vulnerable women, and poor road condition and lack of female health worker. In Bangladesh, health worker status is almost equal man and woman. So that women always prefer to take service from a woman health worker. And what kind of challenge actually community health worker face? One of the major challenges they face in their capabilities, delivery capacities, behavior with the poor and hard to reach area. This is ethnic minority people, because they have some language problem, and medicine supply. They receive partial dose, so that kind of things encourage them to go to the community clinic, because they're the excluded group from community clinics. And lack of resources is another reason, because this community clinic is maintained by community people, and there is a lacking on community ownership, poor water supply, equipments, electricity. All are the areas there is the gaps, and there is a strong lackings on monitoring and supervision by the senior level staff or local level, senior level, supervisory level staff of community health worker. There is a huge gap on these areas. That's why they are a little bit reluctant on these areas. And job in security. That is, this community health worker is recruited and managed locally. So anytime they can lose their job, or they will face problem. That was another challenging area for the community health worker. And to mitigate all those areas, we already initiated some innovation. That is we have included vulnerable population in the community groups, so that they can work is a bridging ethnic religious minority groups to community health worker, share the findings, equity gap analysis, challenging findings to the health system people who are mainly the decision maker at community level. And we provided microdose equity session to the related to social norm and other things to the counterparts, so that to sensitize them and integrate these inclusion issues, health worker supervision list, so that they sensitize on this issue and insert respectful care issues in community health worker orientation and counseling apps. These are the areas. Thank you very much.
Thank you very much, Nadira, for sharing. It's a really important project, and yeah, it was really great to hear from you. So now I will introduce our next speaker, Kate O'Brien from Pfizer. She will speak about a very nice partnership that CARE has with Pfizer. Particularly the Pfizer fellows that are supporting us with the development of costing matrix that will really be a really important tool to have a better understanding of the actual costs of a gender transformative community health worker program. What are the components of such a program, and how much should it actually cost to invest in that, so that the community health worker program can be effective and really responds to the needs of female community health workers. So yeah, excited to hear from you, Kate, about the ongoing work on this costing matrix. Over to you.
Thank you, Marielle, and thank you for the opportunity to speak to you today. So as Marielle had mentioned, I work at Pfizer, and I am part of a program called Global Health Fellows, which is a skills-based volunteering program. So along with 3 additional Pfizer fellows, I was partnered with the wonderful people at CARE on the project I'm about to present. And as you've been hearing in this session, we're talking about how to elevate the status and working conditions of community health workers. In my section, I'll go over an approach that identifies the possible gaps in a community health worker system and what it would cost to fill those gaps. Our remit was to create a costing matrix for establishing a gender transformative work environment for CHWs. So we approached this ask as shown on this slide. First, the situation. We define the situation as when community health workers are not adequately supported, we are endangering the health of the community. Next, our analysis had 2 steps. Step 1 was to determine the factors that, if in place, would establish a sustainable, gender equitable CHW system. Step 2, we developed a tool to estimate the costs of setting up those factors. Finally, our outcome is a costing matrix, which can estimate the budget required to support a gender transformative CHW program and can be adapted for a country's specific needs. So now on the next slide, let's dig into those two steps I mentioned, the factors and the cost estimates. So in working with CARE and partnering with a team in Bangladesh, we identified these factors as being necessary to ensure sustainable working conditions for CHWs. In other words, these are the elements that aim to support and reward CHWs and ultimately keep them doing what they do best, keeping people healthy. So two things to note about this list of factors. First, this list is adaptable to a country's specific needs. So factors can be added or removed or prioritized based on what exists or doesn't already exist in a system. Second, and it's not shown here, for each of these factors, we identified what are the specific tasks that are required to achieve that factor, and who within the health system would be responsible for working on that task. The person may or may not already exist in the system. So for example, the first factor on the list, clearly defined CHW responsibilities. So the related tasks for that would be to oversee job descriptions, the creation of job descriptions, and provide updates as needed. Now, who does this work? In our example, let's say the work is done by supervisors. So now that we have a list of what is needed, let's consider how to convert these needs into costs, and that's on the next slide. So some of those factors are goods. For example, if you have a device like an iPad, that can be readily translated into a cost. For the other factors that are not readily translated into costs, we first converted them into headcount. So to convert into headcount, we estimate what is the workload required. And another way to think about workload is how many hours per week are required to do that task. And then to scale up beyond just one worker, we need to know how many of those workers exist in the system. So now we're gathering inputs for our formula, which you'll see at the bottom of this slide. I'll walk through the formula, then I'll share an example. So first, as I said, to convert these factors into headcount, we need to take the additional hours of work per week to complete the task, multiply it by the number of workers, those number of staff members in the system, divide that by 40 hours of work in a week, then you have a head count. Multiply that head count by a salary. Then we have a cost estimate. So I'll walk through it again with that formula with an example. So sticking with that first factor in the list, which as I mentioned was setting up clearly defined CHW job responsibilities. We said that the work would be done by supervisors. So what's the workload? Maybe it would require 1 additional hour of work per week. And how many supervisors are there? Let's say in this example, we're working at a county level and there are 12 supervisors. So 1 hour times 12 staff members divided by 40 hours per week equals 0.3 additional headcount. Taking it one step further, if we multiply the annual salary, let's say they earn $1,000 per year. So 0.3 times $1,000 equals $300. In this example, it would cost $300 to set up clearly defined CHW job responsibilities. We repeat these steps for all the factors and arrive at a headcount, need, and total cost. So this existing costing matrix, it sits in an Excel spreadsheet, and we're currently pilot testing it with a few countries and fine-tuning it as well. So in summary, this matrix provides a menu for what factors are needed to support a gender transformative CHW program, and then converts those factors into headcount and ultimately costs. Thank you for your attention, and I'll turn it back to Marielle.
Thank you so much, Kate. Very exciting indeed. We are really looking forward to finalize the testing of this matrix, working with the teams in a few countries in Asia and Africa. And yeah, finally, we hope this will be a tool that we can be made widely available for, using it in our advocacy, in our engagement with governments, with donors, and yeah, to really work towards an evidence-based increase of funding in community health worker programs. So thank you so much, Kate. I will now introduce our final speaker of this session, and that is Anna Avillanosa. She is the executive director from an organization called the Southern Tagalog People's Response Center, based in the Philippines. And she will speak about the development and implementation of a digital training tool for community health workers in the Philippines. The center, the Southern Tagalog People's Response Center, partners with CARE and a tech company called Dimagi in a larger care-led initiative called the Heal Hub, which we are currently rolling out in the Philippines. We are also in conversation with other countries to see how we can make this tool, this digital tool, widely available as a critical complement for training for especially female community health workers. I was in the Philippines a couple of weeks ago, and I visited some of the sites where community health workers are being trained on this tool and are using it. And it really made me very excited about the potential of this tool. So Anna, please, over to you.
Yes. Thank you, Maria. Thank you for the opportunity to speak in this event. So, yes, good evening from the Philippines, the favorite destination of typhoon this month. So, I just to start with the Philippine context and the BHW. So, the community health workers here is called barangay health workers. So barangay is the smallest administrative unit. This is composed of 300 families. So BHWs are essential in providing health services and education to millions of people in need, especially those living in the communities struck by poverty and living in remote areas. So in the Philippines, we are geographically isolated. There are many communities. So also there is inadequate healthcare infrastructure and vulnerable to typhoon and other natural disasters. Just like what I mentioned, that within the month we have 6 destructive typhoons. So BHWs, despite their life-saving role and being bridges between the public health sector and communities, often lack adequate support in terms of payment. The BHWs here in the Philippines only receives $5 to $17 per month. And also there is also inadequate supplies of medicine and medical equipments, and also the training because of limited resources of the government. So majority of the BHWs are women. They also face gender-related challenges and inequities. To improve the quality of their services and their skills development and empower the BHW. So there is the Heal Hub was launched in the Philippines in partnership with CARE. So this is designated to provide remote, scalable, and up-to-date ongoing healthcare education to BHW. So Heal Hub has the potential to improve the health outcomes to millions of Filipinos and even in other countries when scaled up and supported by the government. So next. So as you can see in the picture, these are the barangay health workers. So Heal Hub aims to target to reach 1,500 BHWs in Quezon Province by the end of 2026. We just started last February this year, 2024. So BHWs are provided with smartphones, and then the Heal Hub application is downloaded on it, and then modules and educational videos about maternal and newborn health, infectious diseases, and hygiene is translated to local language and can be accessed via online and offline. so that BHWs can comfortably incorporate technology in their day-to-day healthcare. So because you can see in the picture, majority of the BHWs here in the Philippines are senior. So that's 60 years old and above. So hands-on training and peer mentoring by younger BHWs is critical to overcome this challenge related to using digital technologies and help to boost BHWs' confidence in using HealHub in the provision of their services. Please, next. By using the self-paced learning model within HealHub, enables the BHWs to learn their own pace, access content anytime, and apply what they learned in the practical and in their communities. By using the content as both a personal resource and a job aid for counseling patients, BHW can directly impact health behaviors in their communities, improving health outcomes and promote health literacy across families. So this is flexible, accessible approach to learning. So this is essential in the part of building strong, resilient healthcare system here in the Philippines. Next, please. So you can see in the picture, this is the box. So upon completing a module and successfully completing the module, a knowledge test is done. So participants will earn a badge. So the digital badge system in HealthHub is a powerful tool that validates the hard work and dedication of the BHW. It provides recognition for the accomplishment, boost their confidence, and enhance their credibility in the community and the health sector, and provide them to continue learning and improving their skills. So this is also opens the door to greater career opportunities of the BHWs. Next, please. So the HealHub project focus on inclusivity and accessibility ensures that all BHWs, including older health workers, have the tools and support they need to succeed in their role. So we can see this, the BHWs assisting the pregnant patient. Moreover, through advocacy and collaboration with the Department of Health here in the Philippines at different levels, HealHub is working to integrate the BHWs in the formal health system, incorporating digital government learning platforms such as telemedicines, chat forums, or direct communication with the healthcare professionals, private and government, allowing BHW to completely access guidance and ensuring timely referrals and medical intervention. There is also ongoing advocacy for fair compensation to addressing the systemic challenges, including the gender-related challenges that prevents the BHW from realizing their full potential. So through this HealHub, it's creating a supportive and sustainable environment for BHWs, ensuring that they have the resources and recognition they deserve to improve the health outcomes for their communities. So that's it. Thank you.
Thank you. Thank you so much, Anna. Such an exciting project, and I really I've been thinking a lot about the barangay health workers working under these very challenging circumstances, also with the typhoons. So yeah,
Yes.
thank you for all your fantastic work, and wishing you a lot of luck with the aftermath of the typhoons for sure. We'd now like to show a short video before we open the Q&A session. Thank you. I just learned that we have been joined by a community health worker from Sierra Leone who is also going to be on the panel with us. And before I give her the floor, I first wanted to also give some attention to David Bryden's question. David, maybe you want to speak, or I think this question is addressed to Kate. But yeah, David is wondering, Kate, if our costing matrix would also be able to address nutrition and the estimate available for investment in community health workers to reach goals on nutrition. And the matrix is still very much under development, but yeah, do you think that this can also be adjusted to that?
Yeah, great question. Thank you, Mariel, and thank you, David, for asking it. And my initial reaction to that would be, well, the costing matrix is set up to support the community health workers to make sure that they're retained, that they are feeling good about their work, and that they keep doing what they're doing. If there are specific health goals that are needed to be met, I feel like this matrix is initially set up to complement the work that's being done. So I would bounce it back to you, David, for maybe a further conversation. What exactly is needed? What do the CHWs need to do? And I would once again break it into workload. And does this mean there needs to be an increase of headcount? And I'd want to bring in a healthcare expert to say, like, something like childhood malnutrition. That's a massive ask, and it's hugely important. And we need experts to break down what is the work that is required. Do we need more CHWs? And then, yes, to finally roundabout way answer your question, yes, that could be factored into the matrix. But we don't have an answer for it. It could be factored in. I hope that's helpful.
Yeah, David, do you have anything to add?
It sounds like he might be in a place where he can't speak up, but I'm happy to speak at another time if that is good. So thank you.
Yeah, and I also saw a question from David about governance mechanisms and global health governance, and that's also very much a priority in our She Heals the World initiative, to really look at both global health governance mechanisms at the global level, also at the country level, to get an assessment of how many community health workers are directly included. We believe there's still a long way to go. So that's very much part of our advocacy and also of the support that we are going to provide in the coming years to increase that number. Very, very important. So thank you for raising that, David. Before we open it up for a few more questions, Baindu, I'm so happy you could join us. Baindu Mansare is a female community health worker from Sierra Leone. And Baindu, please, if you have some remarks to make, that would be great to hear from you. Thank you.
Thank you very much. Thank you. I am so happy for all what you have said to me. My name is Benu Mansare. I am a Sierra Leonean. My village is Dogbogoma, Bauma Chiefdom Bo District, Sierra Leone. I am CHW at the Yamandu Health Center. So I did a great role in our community. I work with pregnant women. I work with lactated mothers. I work with under fives. I work with women of childbearing. I work with under five. I used to take them from the community to the hospital. If there is any sick, or if there is any danger sign, or if there is any malnourished child, I will take them to the hospital. Then some of the danger signs: edema, pneumonia, red eyes, diarrhea, swelling face, malaria, fever. So some of those are the danger signs.
Hello. Hello.
We can hear you. Yeah.
Yes. Yeah, she was just saying some of the work she does in the community. She closely work with the health facility to do visitation of patients, house to house sensitization. So like when she meets maybe a particular sick person, um, she will look at the case and assess. If she sees these those danger signs, she cannot treat, she will refer them to the hospital. Um, yeah, so she was just saying some of the work she does.
Yes.
Then,
Bindu, maybe could you speak to some of the challenges you are facing with your work and where you could need more support?
The problems, challenges.
yes,
What are some of your challenges?
some of the challenges that we have: one, we are lack of logistic, medicine, the behavior of the community, some of the community people, incentive. Then we are doing volunteer work. So we are going to talk to you people to help us.
Hello, Mary.
Yes. Yes, those are really significant challenges because you are doing this as volunteers. And so it's sometimes really hard, I'm sure, to keep that work going without access to fair payment and the necessary supplies and medicine and other equipment that you need. And so I really want to thank you for being here. It's so important to learn from you and from other community health workers about their specific contexts and the challenges that we face. And today also in this session, we really hope we can take some of these learnings forward and continuing to to continue to have an exchange with you in different spaces so that we can work towards a strategy to improve the situation for community health workers in Sierra Leone and in other places. So I really want to thank you, Bindu, for sharing. And do you have any other issue you would like to raise? Because we need to wrap up in a few minutes. So
Then I want to tell you about the climate changes. The the climate change. Some of our communities, the wind is disturbing us. They cut the trees down. Even my community, we have started to plant some trees. You know, if we have big trees in the community, the sun will not, they will not feel hot. Then the water will not dry. The fishes will not die. Then the place will be green. We will green our compound with some sources.
Yes, and so we see that, of course, in many places across the world, the devastating consequences of climate change on the health of communities. And that's also, I think, a role where community health workers have a really critical role to play to mitigate the consequences of climate change. But there's also, of course, a lot of learning there, and also a strong need for further training. So we as CARE also are looking to use our digital health solution, the Heal Hub, to also integrate courses for community health workers on climate change and how to address these challenges and work under these difficult circumstances and the impact on the health of the communities that you serve. So that's a really important area of work. And also thank you for bringing that up, Bindu.
Thank you.
Thank you so much for being here. And we very much look forward to continuing conversations with you. Thank you. So if there are any further questions, I'm going to put my email in the chat. So please feel free to reach out. And we will make sure that the questions are relayed to the panelists after this session. So I want to thank everyone very much for joining this session. And special thanks to all the speakers as well for sharing all your great experiences and the projects and tools that we're all working on together. And yeah, looking forward to continuing the conversation and the journey to support community health workers in the critical work that they do. Thank you so much and have a great day.
Thank you.
Thank you.
Thank you,
Thank
Mary.
you. Bye-bye.
Thank you. Bye-bye.
Thank you,
everyone.